And so this is where I would actually say non-native English speaking
Wow.
providers and healthcare professionals have a leg up. They are actually putting more effort or have an advantage over their native English speaking counterparts because they're already aware. Your native English speaking colleagues are probably not going to do this as much as you might because they're not aware.
Hello, everyone. Welcome back to Frustrated to Fluid. Thank you so much for being here. And today I am speaking with Dr. Christopher Behringer. He's a board certified family and lifestyle medicine physician based in South Central Kentucky. And he focuses on patient-centered holistic care for underserved communities. He specializes in non-drug treatments, helping to establish the region's first acupuncture and osteopathic manipulation clinic, which has successfully reduced pain and improved patient mobility. He introduced lifestyle medicine to the area, helping patients achieve disease remission, lower medication use, and take control of their health. And he's also a professor of family medicine. He teaches at Lake Erie College of Osteopathic Medicine, which is the largest medical school in the US, and serves as Chief Learning Officer of Real DX, designing educational tools for healthcare professionals. He has spoken at national conferences and universities all across the US. So, Dr. Behringer, thank you so much for being here.
I'm very excited to be here. Thank you so much for having me.
Thank you. Thank you. So I wanted to talk to you today about person first language because I know as someone who works with non-native English speakers, this is something that they struggle with. Just today, I had a member reach out to me and said that they're not really connecting with their patients and they're feeling very frustrated about it. So I'm really glad to talk to you about this because I know that this is something that you do when you're teaching. So can you explain the importance of person first language in healthcare, especially those new to working in English speaking environments?
Yeah. So person first language can probably be best defined by how the National Institute for Health defines it or suggests how you use it, which is you describe what the patient has, not what the patient is. And so a very easy example of this is that instead of referring to a patient as, oh, you are diabetic, you say to the patient, you have diabetes. Or if you're talking to a colleague, instead of saying something like the schizophrenic in room 6, you would say the patient in room 6 who has schizophrenia. And what this does is it puts the person first. And it's probably one of the easiest changes you can do is basically put the person first before the diagnosis. No one is a diagnosis. They are people who have diagnoses, and that helps to humanize the patient, both to your colleagues, but also when you're talking to the patient themselves.
That makes a lot of sense just because I remember one time, this was a long time ago, just being getting personal here. I had a miscarriage. This was before I had kids. And I remember the doctor said, that lady who just had that miscarriage. And I was just like, that lady who just had that miscarriage, that was such a hard thing to hear. So I like the idea of person first language because, like you said, it really humanizes the care. And that language is so incredibly important when it comes to care. So I thought that's a great thing that you're doing. Now, do you teach this a lot with your medical students?
I try to, and I also work with my pre-medical students with it as well, that, patients, it can be very difficult for providers to not use what would be the inverse or condition first language because in our brains, we're always thinking, how do we treat the disease? That's kind of our mindset.
Mm-hmm.
And so it can be very easy
Mm-hmm.
to look at patients as diabetic, hypertensive, obese, and things like that, because our brains are in the idea of how do we treat the illness pattern. But I try to tell my students that we are dealing with human beings. And so I try to encourage them to be very careful with their language because at the end of the day, your words are what the patient has to stand on for their entire healthcare. So using person first language, again, puts them at the center and doesn't reduce patients to disease patterns. One of the issues that can be done with condition first language is the moral or societal or emotional implications, such as if you
Mm-hmm.
tell someone you're obese, And in different cultures or something like that, that can imply a self failure. You do not have good control, or you are depressed. And that can imply weakness in certain cultures or in certain demographics, as opposed to, you have obesity or you suffer from obesity or you are going through depression. You are a patient who's going through depression. These are different ways of phrasing it to realize that, hey, this is a person with a condition, not a disease embodied as a person.
Right. That makes so much sense because words are extremely powerful. And if they're not utilized the right way, it can cause a myriad of problems. And something that people might not even realize that the intention is not there to cause this harm, but because they can be so powerful, it can cause unnecessary harm and then unintentional harm. So I think that what you say makes so much sense. Now, how can non-native English speaking healthcare professionals incorporate person first language into their daily interactions with their patients, their colleagues, or their staff?
Yeah. So I think, again, the easiest transition is going to be basically just always saying either the patient or saying the patient's name. Mr. Smith with diabetes, you know,
Mm-hmm.
Miss Nora with hypertension or something like that. That is the probably the easiest transition,
Mm-hmm.
instead of saying the diabetic, or when talking to patients, saying, instead of you are diabetic, saying something like you have diabetes or you suffer from diabetes. And it is
Mm-hmm.
completely fine. And I have done this myself, is as you're talking to a patient, I'll say, oh, and you're diabetic. And I'll stop. I'll say, hold on, I'm sorry. What I mean is you have diabetes.
Mm. So
And
that's how
it
you
is
stop yourself in real time.
right. You check yourself, because
Mm-hmm.
again, we can afford ourselves the forgiveness of, we are in the mindset of how do we treat the disease. And so we are mentally going through the gymnastics of condition first mindset, but we need
Yeah.
to have that change to person first language when it comes out. So you are going to make mistakes, but patients appreciate when doctors are willing to admit that they've flubbed it a little bit, made a slight mistake, erred a little bit, and they correct themselves. That it shows that you really care about the patient, because you're willing to
Mm-hmm.
say, hold on, I made a slight mistake with how I'm talking to you.
That's amazing to hear. Just because something that I hear on my side when I tell people what I do in regards to helping non-native English speakers in healthcare with their language gaps, even people with native speaking doctors, they sometimes tell me, well, I didn't really think that doctors were human because, they see them in such a clinical way or when something is really wrong. So the fact that you are bringing the human part forward by saying, oh, I'm sorry, I made a mistake or I misspoke, that brings that human element that a lot of people don't even realize or even think about in those situations. But like I said, I hear that on my end when people are like, wow, I didn't even know that doctors even thought about these things. And I'm like, yeah, they really do.
Hmm. And it can be
They really do.
very, one of the trends it can be is that I think one trap we fall into is the fact that we are around our colleagues so much that
Mhm.
there is somewhat of a, and I've lived internationally. I lived overseas for 20 years, and I've worked, do international work and stuff. So I understand that, especially when working with colleagues, that speaking in a manner where sometimes we correct ourselves can sometimes carry with it, are you not a good doctor because you're saying you did something wrong, right? There's
Yeah.
that, why should I correct myself? I should sound smart. I should do this. But we need to realize that the patient is not our colleague, at least in terms of the professional sense. They are the
Yeah.
colleague in their healthcare sense. They don't have any stake in that. They have already implicitly trusted you with their health because of your knowledge base. And it's how you express that knowledge to them that matters to them. Can they understand it? Do they feel
Absolutely.
respected by it? That's important. And so I would say that patients, if you correct your speech, it's not even they don't care about it. They actually appreciate it because you're trying to make an effort. And if I will say this for anyone who's listening here, just for every person here who is invested in trying to make their language better, trying to connect with patients better, there's at least 5 or 10 of those who aren't. And so you can stand
Mhm.
very much as that exception. And it's that, hold on, I'm making a mistake here. That patients will think of the other 10 doctors they've seen that didn't correct that mistake And in that moment, you've created that bond of trust.
Absolutely. And as someone who's not in healthcare, I know that if my doctor ever did something like that, I would think that they were the best person ever because you're bringing that human part to it. And that alone just makes the conversation so much better. It makes it so much easier, especially if something is going wrong. So I really appreciate what you do and bringing this to the forefront. So what challenges do medical students and healthcare professionals face when adopting first person language, and how can they overcome these barriers? I know that you talked a little bit about the mindset, but is there anything else or any other issues that they have and how they can overcome them?
The biggest one is going to be that, again, most of your colleagues and our colleagues are going to default to condition first language. In fact, I would say that we always default to condition first language, and it takes a lot of effort to not use condition first language. And I think this may be more so true to an extent with even native English speaking providers and health medical students, as opposed to non
Mhm.
native English speaking. And the reason is because they take their English for granted. I talk to people in English around my community all the time. Therefore, I must be easily understood.
Mhm.
And non-native English speakers who are making an effort to, change their speech patterns are significantly more cognizant, more aware about changing their speech patterns. And so I actually see this being an issue more so with native English speakers sometimes because they are understood in their day-to-day life that they don't see a need to change their speech. And so this is where I would actually say non-native English speaking
Wow.
providers and healthcare professionals have a leg up. They are actually putting more effort or have an advantage over their native English speaking counterparts because they're already aware. So those are the challenges. Our colleagues are going
Mm.
to do it. Your native English speaking colleagues are probably not going to do this as much as you might because they're not aware. Because again, I'm easily understood in my day to day life. So
Mhm. Mhm.
that's going to be the biggest thing. And the way of overcoming that barrier is I think the first thing is just in your individual patient interactions and in your own head. You know, you realize that you are thinking condition first for the purposes of the medical care of the patient, but you are using person first language when you actually talk to them.
That is so interesting to hear because as someone who exclusively works with non-native English speakers in healthcare, this is something that is such a huge issue in their mind. They always want to make sure that they are understood because they're so worried about their accent or being viewed as less than or the
Mhm.
cultural differences. So the fact that you as a native English speaker is saying, hey, non-native English speakers actually have a leg up on this because they're aware of making sure that they connect with their patients because of the language barrier is so fascinating to hear. I think that's amazing. So in regards to this idea of bringing humanity back into healthcare, because I know I've talked to you previously, and this is something that you are very passionate about. You really care about the advocacy of the patient and bringing that human element into medicine. So when it comes to person first language, thinking about bringing it back to humanity, why is that especially important for non-native English speaking professionals in regards to their accent? Because like I said, this is something that is a huge thing for them. They feel like their accent alone is a huge barrier. So how can that alleviate that pain point for them in regards to
Mhm.
bringing the humanity into the language?
So as someone who lived internationally and kind of came not necessarily as a non-native English speaker, but with what would be called a third culture kid accent and or linguistic pattern, meaning that I am ethnically one culture. There is a dominant culture that I'm living in. And then there's the amalgamation of cultures because I had my high school of 52 nationalities and 500 students. When I came to the United States, in my opinion, the accent seems to be more of a point of contention for the speaker as opposed to the listener due to the inherent nature of the United States being a country of immigrants.
Mhm.
It is very normal to hear accents in your day to day life, to hear multiple accents in a single household, to hear multiple accents in a single family unit. It is, I think, significantly more common. However, it does lead to an auditory barrier for some people, especially this is going to sound very strange, but I work in South Central Kentucky, and I've worked with some people who have very thick Southern accents. And I've had one or two patients tell me, I have a hard time understanding your accent. Me. Yeah, which I feel I have a
Wow.
very, neutral standard American
Yes.
accent. But they are
Very
so used to
neutral.
being, yeah, they are so used to their community and their accent that I was not understood as easily by them. So I have adopted some mirroring. That's very normal. But what I would say in terms of the accent is I think it's more of a point of contention for the speaker as opposed to the listener. Hearing accents is very normal. And so
Mhm.
a lot of these biases can be overcome by using person first language. They're still coming to you for your knowledge. The person first language is about your ability to communicate your knowledge. And so if you're able to put the person first, communicate the knowledge in a way that they perceive as respectful, the accent tends to fall down by the wayside, in my opinion, because again, they're about to leave and
Yeah.
hear 4 or 5 accents before they get home in their day-to-day life. And so that is something I would say is that focus on how you communicate the knowledge. The accent will kind of fall by the wayside at some point because you're trying to establish using person first language, you're allowing them to hear, you have diabetes, you have these things. And that leads to other things. It leads to questions, it leads to education, it leads to discussion, it leads to conversation when we use person first language. I
Mhm.
liked the way that you discussed it, is that it's a conversation. It can be
Mhm.
very common to refer to the medical encounter as a consultation, meaning that usually if we think of a consultant, it's I pay you, you tell me what to do, and I just go and leave and go do that. That is not what medicine is. It's a conversation where they are the drivers of their healthcare. We just have the map. We have the directions. We have advice. We have ways of getting there. And so
Yeah.
that's the way I see person first language being bringing the humanity back into it, especially in the United States.
Right. And I'm glad that you touched on that because my children's pediatrician, he's not from the US and he has an accent. And honestly, I could care less about his accent because I understand what he says. And whenever I ask him a question about their health, he's very confident in his answers. So
Hmm.
his accent is completely irrelevant. So I'm really glad that you touched on that. And then as far as the misconceptions, again, I know that you touched base on this a little bit, but what are some common misconceptions about person first language and how can healthcare professionals avoid falling into those traps?
Right. So one other thing that leads from person first language. So although person first language is defined kind of initially as putting the person first, other aspects of it can be let the patient, again, put the person first. So if you give them a hard diagnosis, you know, saying things like, I know this can be difficult might sound actually patronizing because you're putting yourself first, actually. So instead, asking
Oh,
things like, instead of saying, I've seen this be difficult for many people. Again, if I give the diagnosis of cancer to someone, I cannot truly empathize with that. It is objectively, this is a difficult situation. How are you handling it?
I see.
Difficult situation. I do not know how difficult this is. I do know that it is a difficult situation. You tell me why it's difficult for you. Because, for example, I diagnosed a patient with cancer and they're in their 80s, and they said, this is so bad because my daughter, who's in her 50s, has cancer, and I was helping take care of her.
Oh,
And I
wow.
could never comprehend that as
Wow.
I could never have thought that is difficult for me. I just objectively know cancer is difficult, but what it does for the people around you. So that's putting people in front. Now, or if someone has a question or a concern, they're like, oh, this feels very difficult for me. And when we reinforce that and say, yes, it can be difficult. Tell me more about it. Tell me why this diagnosis is impacting you. What some people may perceive this as is baby talk. This is babying the patient. This is,
Mm,
for example, if you give them a diagnosis of like, for my healthcare providers, they're going to understand this. Like, say you give someone a diagnosis of diabetes and their A1C is 6.8 and they are freaking out. And you don't bother to ask why they're freaking out. And you're just like, it's not that big of a deal. An A1C of 6.8 is like, okay, maybe one medicine, some lifestyle changes. Like, this is not going to be that bad. This is not going to be. But in the back of their mind, they're thinking of their grandfather who was on insulin and had an amputated leg and went blind.
mhm.
But if you lead with, it's not that big of a deal, which medically, again, we condition first. Medically, we are thinking it's not that big of a deal why you're freaking out. But if we put the person first and you read the room and you say, wait, why is this freaking you out? It opens up an opportunity. That's not babying them. That's opening up an opportunity for them to engage with their health, to realize I have control over this. This is giving that ability to assuage their problems and also say, what are your concerns? Oh, those are your concerns? Well, here's how you more actively prevent them. When patients are showing concern, they're showing a desire for interaction. Like they are just showing a desire to be engaged. They want to also have control. And so asking them, why are they concerned, might open up a conversation of giving them back control. Because again, they're there, they see you as the pillar of strength. You are the doctor. And
Mhm.
so a lot of people may look at person first language as baby talk or flowery talk because people are soft, but that's not true. It's because different people will perceive different conditions differently. Doctors are used to talking to doctors. And so, you know, we are used to condition first language, but we aren't, but when we talk to patients, they may take it differently. So that's probably the biggest one is it's not soft talk. It's not baby talk. In fact, it can lead to better compliance, better engagement, and in my opinion, more efficient care because again, a patient who is invested in their healthcare has better outcomes. There are even studies by the American Diabetic Association that shows that using appropriate language leads to better diabetic outcomes because patients who feel respected are more compliant.
Wow, that's fantastic information. I'm really grateful that you are demystifying this because I can see how someone would think that they're babying someone, but when you explain it in that way, it's the exact opposite. So I appreciate you explaining that. That's very, very effective way in regards to speaking to a patient. Now, before we wrap up, do you have any final thoughts or any last words that you'd like to say for our listeners?
Other than that, what I like to say about person first language is be the reason that your patients are inspired about their health. And that's how you can use the language. They are coming for you for that conversation, for that education, for that guidance. And so you can help again, you yourself can demystify things for them. And so you can be the reason that your patients want to be healthier.
All right. Thank you so much, Dr. Behringer. This was an amazing conversation. I'm so excited just because I know that this is the kind of information that people need to hear. And so the fact that you came on here and you expressed the importance of this type of language, it's genuinely going to help people. So thank you so much. How can someone reach out to you?
So, I've got my email, cbmed@yahoo.com. I've got my phone number 407-989-3904 with the American 1 in front of that code. I also have a LinkedIn, so feel free to connect with me there.
Awesome. Thank you so much. Thank you for listening to Frustrated to Fluent, and we will see you next time. Take care.